From the JAMA Network, this is JAMA Otolaryngology Head and Neck Surgery Author Interviews. Conversations with authors exploring the latest clinical research, reviews, and opinions featured in JAMA Otolaryngology Head and Neck Surgery.
Hello, and welcome to our listeners around the world. I'm your host, Dr. Paul Bryson, the director of the Cleveland Clinic Voice Center, and your media editor for JAMA Otolaryngology. Today, I'm delighted to be joined by colleagues from the Sidney Kimmel Comprehensive Cancer Center in Philadelphia. I'll be joined by Drs. Jennifer Johnson and Dr. Adam J. Luginbuhl. Dr. Johnson's a medical oncologist, and Dr. Luginbuhl is a surgical oncologist. Welcome to the podcast.
Thank you.
Thanks. It's great to be here.
Well, today we'll get to talk about your recent article on the effect and survival in HPV-negative head and neck squamous cell carcinoma following a neoadjuvant Nivolumab. Congratulations on this work. I know it was a team effort. Could one of you kind of give us a little bit of background on this? You know, as a laryngologist, I'm certainly aware of this work, but I'm not living it day to day. And it's really been exciting to see this work come to press.
All right. Yeah. So this is definitely a topic of passion for both of us, as we have been in this space for the past almost 10 years now, along with colleagues from around the world, asking the question of how does immunotherapy interdigitate with our world of head and neck cancer? So essentially 2 trials. We've run a number of trials in this neoadjuvant space, and 2 of them were done over 3 to 5 years ago. And so we wanted to go back to those trials to ask that ever important question of how does this really affect our patients in the long run, aka their survival? Jen, maybe you can comment on the medical oncology side, what this means from where we were to now where we're going, especially with the announcement and the publication of the recent Keynote 689 trial in the New England Journal of Medicine.
From the medical oncology perspective, we've had the opportunity to treat our patients in the recurrent and metastatic setting with immunotherapy since 2016. And unfortunately, that leaves a large proportion of our patients waiting until things have gotten really bad, until you have recurrence, until you have metastases, to be able to benefit from this exciting new form of treatment. And so these neoadjuvant clinical trials are really bringing immunotherapy into the state where we meet most of our patients, which is not when they are metastatic. It is either a locally advanced or just a local disease. And we wanted to be able to see how we could bring these treatments to them.
As you describe the work here a little bit, can you break down who are these patients in terms of primary tumor site? How did you sort of identify which group you were going to include?
These 2 trials, or 3 trials here that are represented in this paper, we had a pretty nice inclusion criteria. They were investigator-initiated trials, and we were pretty expansive. So we include both early and later stage tumors as well as HPV positive and negative. So half our patients were HPV positive, half were negative. And because it was an IIT, it gave us some of the freedom to look at staging as well, not just the advanced stage, which we see in the 689 trial, but essentially people that are untreated, and they're going to get their first run at immunotherapy before surgery. And ultimately, just to move it into the paper itself, we saw a response in some of our patients, a pathologic response. And so that pathologic response is essentially take the tumor out, give it to our pathologist, and they give it a grade of how much tumor is actually still present versus been destroyed. We're going to call that the pathologic treatment effect. And then the paper itself, we wanted to go back and ask those numbers that we got from our pathologist years ago, where are those patients now? And so that population has matured now, and we wanted to ask, did those responses that we had back then predict how they did years later in terms of their survival? Specifically in this paper, HPV negative, right? HPV positive, when you looked at our group, really we wouldn't expect to see much of a difference because they do so well overall no matter what. And we didn't see a difference. But when we looked at just the HPV negative group, that's where we see some excitement both here I would highlight some of our colleagues, Dr. Weiss-Draper and Dr. Otolaryngology, and previous papers also did a very nice job of showing some of this. So just the body of work is building. We're hoping to add to that body of work.
Yeah, and it sure seems like a paradigm shift in the patient journey. When you sit together on tumor board and you have now been working in this space together for so many years, what does tumor board look like these days?
I guess tumor board looks like a lot more of me talking. No, in tumor board is a lot more possibilities now. Tumor board has always been collaborative. I've been on the faculty here for 10 years and really been lucky to work with a very open-minded group of surgeons who are very collaborative by nature and who are always looking to improve what we can do for our patients. And we've been doing this over and over again with immunotherapy and hoping to be able to bring this into the neoadjuvant space, hoping to bring this into locally advanced treatment. And so that's the tone in these conversations. We're able to talk in tumor board about possibilities and looking at where we want to see the patient journey evolve into. Pathologic effect is something that we already know as medical oncologists and can borrow a lot of information from other tumor types. We talk about it as a surrogate endpoint in clinical trials in breast cancer. We know that there are already data coming to us from non-small cell lung cancer, from bladder cancer, and it's really wonderful to see head and neck join those ranks.
When you talk about pathologic response, so when you're in surgery, maybe you have a group in this paper that you're excited about the response. Can you grossly see a response at the time of surgery? And then I'm sure there's papers in this space, but have your surgical procedures changed somewhat? You're a large cancer center. We have a large cancer center here in Cleveland, and you have a big team of reconstruction folks. So what are you seeing at the time of surgery in these folks? And I want to talk about the pathologic response as well. When you go to the OR, what are you seeing?
Yeah, for listeners out there that are just approaching this for the first time, I want to just put a plug in for something called adaptive surgical timing, a term we coined here, and others have also coined it. Essentially, we want to be really careful as we put our toes in the water of this paradigm shift, that we don't just send our patients off to a medical oncologist as a surgeon and say, hey, come back after 2 doses, and it's 6 weeks later, they had no response, tumor now has doubled in size. It's not a hands-off approach. And so I would tell you that the first thing is we do an interim analysis for that individual patient, things that we find that are good. Patient says pain is better. Patient says tumor is smaller. Your physical exam is better. Your CT scan shows improvement. By all means, go get your second dose. If the patient's like, my pain is worse, I feel like this is getting bigger. Your clinical exam, your CT scans are telling you this is not going well. I definitely think that there is some cautionary tale there. And we saw in our recent paper, different than this one and published in Clinical Cancer Research, that when you do adaptive surgical timing, you actually can pick out those responders and push them further. And the non-responders, you get to the OR sooner. So you're not being negligent. You're being thoughtful about patient selection. And you're really trying to adapt your practice with the team. To your question in particular, in the OR, it is a wonderful day. It is a great day when we take a patient. Recently, I think 2 weeks ago, I had a patient that was a T3N3B patient, lateral tongue, took to the OR. Essentially, she had in final pathology 3 millimeters of tumor in the tongue and nothing in the lymph nodes. So a T1, almost T0N0. And that patient did remarkably well and de-escalated to the point where we did not give her radiation as per the protocol on trial. Again, this is a protocol-driven trial, and proceeded with adjuvant immunotherapy. So those are wonderful days. But those days are often preceded by a day when a patient shows up after 1 dose and they're in pain. And so this is something that we really want to stress here, that we be really thoughtful clinicians as we approach this paradigm shift.
Well, it's very exciting, having trained in the era that we trained and to have these options and to see the paradigm shift. It's really exciting to observe. And as you look ahead, what are the next things that you're excited about in this space? Is it your ability to further look at the signature of a tumor and select and be adaptive, like you said, or what's maybe around the corner after an important paper like this?
Like a million different things. So I think we both are excited by so many different parts of this work and the potential of the paradigm shift. I'm excited about the potential for re-examining everything that we already thought we know about neoadjuvant treatment in head and neck cancer. This has been a long debated topic, and we've been stuck by some of the traditional rules of cytotoxic chemotherapy. And now that we have neoadjuvant immunotherapy, not only do we have something that's effective, but it's also less toxic in patients, and we have to sit back and think about things that we once thought we understood. We have to think about radiographic response. We have to think about pathologic response. We have to think about careful design of clinical trials with interesting surgical endpoints to talk about decreasing morbidity associated with treatment as important as some of the overall survival and event-free survival endpoints that we're traditionally talking about. Because if you can get a patient a better functional outcome, that's so incredibly meaningful to their cancer journey. I'm watching for this shift. I want to be a part of this shift with Dr. Luginbuhl and my surgical colleagues in creating those new types of clinical trials. I'm interested in where comprehensive genomic profiling and molecular profiling can take us with identification of patients who are going to be the story that Dr. Luginbuhl just talked about, who are going to be our excellent responders. How do I maximize the number of people who are going to be responding to our treatments? How am I going to find the person who wasn't going to have that brilliant response? And what should I be giving them instead? What other combination of therapies? What are the new drugs that we want to design? And how can we do so in a reasonable way for these patients to get the maximal benefit and minimal harm?
If I were to narrow it down to one very specific focus, I am incredibly, as excited as I am for our future, I am incredibly nervous about it. I am worried about that patient that doesn't respond, thus the paper. And also patients being de-escalated that shouldn't be. So if you look at the response, so in this paper we found, let's just talk a little bit about the data in brief, real quick. In the HPV-negative group, we did a recursive partitioning where we identified basically 57% was the number where the curve switched. If you're below that percent response with neoadjuvant immunotherapy, you basically aligned yourself with a disease-free curve or overall survival curve that aligned with normal head and neck non-treated patients. Essentially, you didn't get any benefit. If you are above that number, no one had a recurrence. Everyone is alive. Now, granted, small numbers, I'm not going to overstate it. I'm not going to overblow it, but there is something there when a patient responds that propagates into survival. What we wouldn't want to do is we wouldn't want to take a patient who has maybe a 30% or 20% response and then take away their radiation, or do something that would potentially, in our exuberance, miss our opportunity to do the right surgery, to do the right treatment. And so understanding what is this pathologic treatment effect, that's what we're striving, all of us, not just our group, but all the groups doing this. I applaud every institution striving to find this out. Also, on the other side, as Dr. Johnson said, when we do have a tremendous response, when it is a T0N0, de-escalating that group so we reduce toxicity on the adjuvant side. That would be my number one thing that I see our future is really understanding who we're treating, who's sitting in our chair.
I really commend you both for the work. I'm excited for the readers to read through the manuscript. And I just wanted to, give you an opportunity for some take-home messages. I really appreciate sort of that personalized care and the caution that seems necessary. These aren't like lumpable patients at all. And it seems like, if anything, they might require a bit more surveillance, particularly in that early phase of treatment, to see which pathway they may need to take.
There's a tremendous amount of excitement in the use of neoadjuvant immunotherapies and tons more work to be done. And as we continue to advance the science, one of the things that we're going to need to be looking at is the way that we translate the science throughout our community of practitioners. As you had mentioned before, we're at a major medical center, you're at a major medical center. But we need to make sure that this new and exciting opportunity is available to all patients. And that the collaboration that we've found here at the Sidney Kimmel Comprehensive Cancer Center is something that we can reproduce to all patients everywhere so that there doesn't become a care gap as we enter into this new era.
Yeah, so well said, Jen. I couldn't agree more. I just think stepping into this with a team and knowing each other and knowing the workflow for our patients will benefit us all, including the patient, and thinking that through, because this is an exciting time with this new publication of the New England Journal of Medicine paper, as mentioned earlier, and little bits where we take and analyze our data, as Dr. Johnson mentioned, gives us just one step closer to understanding that personalized care that we so earnestly search for every day.
I think the only other thing, Adam, you were talking about the way that we had measured pathologic treatment effect as being about the viability of cells left behind. And that's certainly been the way that we have always approached pathologic treatment effect before, because with cytotoxic chemotherapy, it's fractional cell kill. Cell is there, cell is dead. Pretty easy. The mechanism that we have with immunotherapy is now you're going to have an infiltration of immune cells, you're going to have cell death that's occurring over a different timeline. It's not quite as predictable. And the work from Dr. Weiss-Draper, Dr. Otolaryngology has really looked at some other aspects of pathologic effects. That infiltration of immune cells, the evidence that there has already been an immune reaction in that area is perhaps going to need to be just as important as cell viability as we're moving the field forward, and we're looking for cues about which patients are going to behave in what ways and what additional therapies we might be able to offer them.
Thank you both for being on the podcast, and I'm excited to see your team's contribution to this space.
Thank you so much.
Thank you for having us.
This episode was produced by Shelley Steffens at the JAMA Network. You can find a link to the manuscript in this episode's show notes. To follow this and other JAMA Network podcasts, please visit us online at jamanetworkaudio.com or search for JAMA Network wherever you get your podcasts. Thanks for listening.
This content is protected by copyright by the American Medical Association with all rights reserved, including those for text and data mining, AI training, and similar technologies.